So good afternoon, everyone. I think after this nutritious lunch, it's very tough for now our panelists to really engage you. So we will change the script. I request K-Corp to give me the liberty to change the script. We will ask, instead of two questions, only one questions to each panelist. And we will give opportunity to the uh, audience to ask two questions. So it will be a different. You will be a moderator this time. So I think to just set the context, I just first of all like to congratulation and appreciation for K-Corp, especially Vaibhavi and her team for bringing together the government stakeholders, development partners, and nutrition experts to have this very important discussion on nutrition program. So congratulations to the K-Corp team. And this session is more toward the community-based approaches or interventions. And all these panelists, they have worked a lot in community and will be sharing learnings from their experience related to these community-led approaches. And we all know that government is also focusing a lot on community-based approaches. And if you see most of the guidelines now, government guidelines include one chapter on Jan Andolan. So all these interventions are very important, and we have heard from previous panelists on all these things, community-based approach, behavior, and all those things. So I will start with Rajni, Ms. Rajni, with you. Already, I think in briefing, it has been mentioned your very important initiative, which is Mom Split. And this is, I've heard it's like a Swiggy or Zomato-like system providing a hot cooked meal to mother directly. And the outcome was very encouraging that there is a hemoglobin improvement and also the birth outcomes, all these outcomes are good. So my question to you is, first of all, if you can share, highlight what you have done in this and the outcomes related to this. And also, how can we transition from the traditional take-home ration or THR approach, which currently ICDS use, to this kind of approach, a meal directly to mother? Because take-home ration is usually consumed by everyone. We know that it's not coming directly to the mother. So how we can do that? Over to you, ma'am.
Thanks. Thank you once again to K-Corp, all the organizers for this opportunity. Thank you, Dr. Prem. Yes, so I think since morning we've been hearing a lot of deliberations. A lot of good points have come up. Almost everyone is talking about integration. And you know, even we, I think I can vouch for all the panelists who are sitting here. When we were walking on ground, we also realized that the issues were similar. How do we integrate? How do we bring in nutritionists? How do we bring in academia? How do we we address adolescents, early malnutrition, etc. And that is how, you know, this particular intervention called Mom's Plate was conceived. So what we all know is that during pregnancy, the calorie requirement increases by around 300 to 500 per day. And the take-home rations are available, but it's more of a household supplementary food. We know that women eat the last and they eat the least. These are the factors that all of us know working on ground for so many years now, and things have not really changed so much. But what we also know is that the indicators, if you see all the data that is available to us from NFHS or other studies, it says that maternal anemia is still an issue, adolescent anemia is still an issue, there are low birth weight babies, somebody talked about the BMI earlier, the weight gain during pregnancies, these things still remain an issue. So what we thought of doing is providing hot, cooked, tailored meals at the doorstep of the pregnant women. And we have implemented this, it's been now almost 2 years, and we served these nutritious, curated meals to at least 1,000 pregnant women in different terrains of Rajasthan and slums of Delhi, because we also wanted to understand, the geographies, the culture, how does that have an effect? What happened was that the women, the pregnant women, malnourished women were enlisted and registered by ANMs or Anganwadis. They were then referred to the self-help group or a local women entrepreneur whom we had trained, or the SHG group women whom we had trained, equipped them with quality cooking practices. We facilitated their FSSAI registration, and we made sure that the meals are delivered to the pregnant woman and consumed by her. And so we also launched a mobile app that tracked, the tech helps us bring in accountability and transparency. So it tracked the delivery of the meals, consumption of the meals, hemoglobin status, the weight gain, the pregnancy progress, etc. But of course, it was tech plus, and there were mother groups, there were father groups, the families were involved to take care of the pregnant women, to provide all the support that is required. The frontline government functionaries were also involved, and we found very encouraging results. What we saw was that the institutional deliveries had increased to 97%. We saw anemia reduction by 94%. Severe anemia altogether, it was gone within our cohort. We saw the birth outcomes. The low birth weight babies had reduced. The normal BMI had improved considerably amongst the pregnant women. So what we found was that all these indicators were very, very encouraging. Of course, these were shared at the village level, the block level, district, national level, and this started getting a lot of eyeballs, this intervention. So we scaled. In fact, with our other resource partners, we probably would be getting into near geographies and in Maharashtra also. So yes, it's been very encouraging. I'll just quote another incident from Rajasthan, Bikaner district. The caste system still is there. So what we found was that the malnourished women who were from the higher caste just wouldn't accept the food if it was cooked by a woman from a lower caste. And that became, again, a cultural issue. And that is where, we thought of delivery agents who are providing and ensuring that the meal is consumed. And that is nothing but like a rural Zomato model, in a very common parlance, if I have to say. So, yes. So these were, in a nutshell, the intervention all about and our results that were. So to answer your question, how does it complement? So this, we are not replacing the take-home ration. Take-home ration is mostly at a household consumption level, but pregnancy biologically needs nutrition, which has, which is very pregnancy focused. And that is how this intervention comes into play. This is not replacing the take-home ration. This is about adding a layer to the meals that are already provided. It adds a layer for high-risk pregnancy. We had an equity focus. We included women from socially excluded groups, adolescent pregnant mothers, high-risk pregnancies. So that equity focus was there. It was very much embedded into ICDS, NHM, Poshan, the Poshan tracker, the SBCC component. It aligns very well with the NHM maternal outcomes. So with the alignment on the ongoing government programs and the schemes, and with the equity focus, I think this really scaled up very well. So I think what we're trying to shift here is a mindset from just food distribution to a mindset for nutrition outcomes. Thank you.
Great. Thank you so much, Rajni, for sharing this. And definitely here you have made a pregnant female as a focus for nutrition activity rather than the whole family. And I still remember you presented this in one of the CRO meeting, and a lot of countries have shown interest in this model. Before I ask the question to the other panelists, I request two questions, but it's a request that please ask questions, not the details. It should be short. So any one of you, question to Rajni related to mom's plate or anything else? Anyone? Yeah, please.
It's really not a question, but I'm just wanting to say that when a woman is served food, at one point in time, especially pregnant women, and a lot of food is being given and she's asked to eat, I think sensitizing the Anganwadi worker or whosoever is responsible for feeding the women to tell, what to eat first. Like the rice would be there available at home also, but the glass of milk or the curd which she's getting, or something which is nutritionally valuable, which the women may not have an access at home, the women should be encouraged to eat that first and then come on to the rice and dal. So this is an observation because when I interacted with one of the Anganwadi worker and she said that, itna khana hota hai, wo bolte hum ye nahi, itna pura nahi kha sakte. So, I went ahead and told her that आपका जो उसका दूध का ग्लास है उसको बोलो सबसे पहले ये तो तुम पी लो या अगर अंडा है तो ये तो खा लो लेकिन उसके बाद जो तुम्हारी भूख है क्योंकि दाल चावल तो आप घर पे भी खाते हो.
Yeah, please. I think we'll take 2 questions and then you can respond. Yeah.
Very nice initiative. I am Dr. Nishi Suryavanshi from Johns Hopkins Infectious Disease Program from Pune. So my question is that, as you very rightly said, that when mother is provided this hot meal, that plate, and it is like always that there are children at home and some other family members. So eating that plate by herself. So did you face any challenges when, and where it is provided, whether it is delivered at home at that time, how you tackle that problem, having the family and she eating the whole plate by herself? Secondly, I want to understand that what are the items in this plate, who decided and what kind of counseling is provided and who provided that counseling? What kind of challenges you faced while implementing this program?
Thank you. So a lot of things had gone at the back end. So for example, how did we, and that'll answer both your questions, how were the meals decided? What are the components, right? So we had a team of nutritionists working. So there was high calorie diet, there was protein rich diet, high iron diet for those who were anemic, low salt for those who had gestational hypertension. So there are these algorithms that are now built in the app. So we have outreach workers whom we called as Poshan Mitras, and they would go interact with in the community with the families. So families are definitely involved. Ashas, ANMs, Anganwadis are definitely involved. There are capacity building efforts, there are training efforts. And because we involve the family, we involve the mother-in-law, the husband, they understand the value of providing nutrition to these pregnant women. So I think that counseling is happening at every level. There are group meetings in the community, the village elders and stakeholders are involved. So we do a lot of SBCC, behavior change component is again a very integral part of it. So it's like once the Poshan Mitra or the registered ANM along with the Poshan Mitra registers this woman and she has a low hemoglobin, the algorithm itself will trigger the meal that is there, which is iron-rich, protein-rich, etc. And it will go to the social entrepreneur. So I forgot to mention that this did not only have positive birth outcomes, but it also increased the income for the social entrepreneur women. There was a monthly gain of 15 to 17,000, and many households reported a 2x increase in their income. So this not only improved the nutrition, but also the household income, and it is an entrepreneur model also. So yes, the counseling was definitely there. Involvement of the family members was there. Involvement of the ASHAs and ANMs, they were definitely trained as to what is required, how much is required. So again, I'm just highlighting and reiterating this is a top-up. This is not replacing the ICDS take-home ration. This is a top-up. So definitely what is missing is being provided and in that kind of quantity. So there are algorithms, which are vetted by the technical advisory groups, which have experts. So yes, so that all went to the background because in a very short time I could just explain that much.
Yeah, thank you, Rajni. Thank you so much. It's a short time. I know you have multiple data and a lot of things. We can talk separately. I'll just move to Mr. Mohan HL. We all know that Karnataka Health Promotion Trust, they have initiated a Gram Arogya model. And this is a model where Panchayat has been given responsibility for health and nutrition related programs. And just a nation want to know the philosophy behind this, how you have engaged panchayats, gram panchayat to basically monitor this program and work on this program, and how we can scale up these things in other areas, if you can share that, please.
Thank you, Mumbai. Actually, we rarely come to Mumbai and address this kind of a group. Generally, we all go to Delhi. So, lot of new faces. Thank you very much. I remember Mumbai quite a long back. I think before setting the philosophy why we started working with Panchayat, I want to tell one story about my experience in Mumbai. I was, in the 1 decade I worked in the education sector, more into education sector. I moved to HI sector. That time Dr. Kera was in NACO. And first time started working with these sex workers and transgenders without knowing anything about them. And developed high curiosity about the sex workers and transgenders. Started working very closely with them, giving paper, asking them to draw things, what you like, what you dislike, all that, trying to explore and learning for me. One thing it is realized, especially in the Bijapur, Belgaum, Bagalkot, we call 3 Bs. And this side in Maharashtra, it is 3S, Sangli, Satara, Solapura. Though states are, boundaries are created, but you can't change the culture, no? These are the old people who are living with the same families, relatives are this side, like India and Pakistan, same, Bangladesh and India. So I started developing a curiosity. These all women, especially Devdasis, are going to Mumbai, Bhiwandi, Budwarpet, all that. I asked my colleagues, see, we should go there and meet the sex workers. So myself and my 5 colleagues, we came to Kamatipur. Kamatipur, we met 10 sex workers. We didn't go just like that because that time our sex workers already tuned what to answer. Only 2 things, condom, STI, condom, STI. Oh my God. Beyond that, there is no life for these people. So we went with the, typically in Karnataka, we have traditionally, we give blouse piece and the bangle, right? We took them, we came here to talk to you. They gave a lot of time to discuss. 35 sex workers we met in all this site, including Pune, Budwarpet. And except one, all of them gave permission to us to go back and talk to their children and their parents who is taking care of their children. And we developed in a we understood very clearly how the trafficking is happening, how the girls are coming, everything, how this transition, because that is part of our job. After 5 years, there is one program we are implementing in Mumbai, orphan and vulnerable children, that is again on the HIV, who is infected and affected. So I had a curiosity, I want to go back and meet them, the 10 sex workers. I again went to Kamatipur. I met only one. Then I asked, she is from Belgaum. I asked that where are others? They told 2, they are already died, like through HIV infection, and others they went back. I asked that why they went back. So Karnataka government started giving 10 kg rice and other freebies. And she was telling, sir, now we are getting all that in our native. We can be with children, and this ration is also provided by the government. That is the time I realized how the food is important for the poorest among the poor. So till today, I don't criticize any freebies provided, especially on food. We may argue that where to give, when to give, how to give. That is a different issue. From morning, I was just observing a few things. That's very good. Nothing against that. We are all talking about scale, right? But the reality is, in the name of scale, we are really missing the people who are supposed to reach. And the whole country is talking about scale. Country realized the people who are migrated, only COVID has to come. Then only they realize people are started walking. So many people are leaving from other state in different cities across the country. Till then, nobody is counted. Even now, no cities have or no panchayat have a counting of the migrant population. But we are talking about scale. Another cliche, we are talking about the community ownership, community, family, individual. You see that last 2 decades, more centralization. We are talking about one nation, one card. We are talking about everything one. See, where is we are going? What is going to happen in that, right? See, now, everybody wants power, but only at their level. Nobody wants to think of power below that, right? And another one is we are talking about AI. Again, I have we also developed one AI tool on TB, but I am not against that. But what is that? In the AI, see, we are bringing lot of things on that. How to make it is community friendly. Okay, to reach the right population. This AI, exactly we are talking about humanity, community connect. Is something is going to happen through this? Or again, we are going to create some kind of a gap. See, the same people we are talking about our own kids don't use social media, bala. So many studies, so many mental health issues we are talking about this side. Other side, we are equipping with another weapon. I think this is again a very, very contradictory. What type of AI we need to do, right? This is all from morning, okay. Then, data. I'll tell you, we all talk about the convergence, no data converge. I will tell you my own experience. Anganawadi, WCD talks about different data. Recently, my experience in one of the state program, they asked me, teenage pregnancy, they asked me, Mohan, what is the data? Sir, as for the NFHS, it shows around 12%. It is roughly, it comes around 1,20,000. Okay, what is the data you have? Only health department has, who is actually aborted in the hospital. That is 12,000. Okay, then another data with the WCD. They talk about 6,000. Then now, police also collects a lot of, so their data, all the 4 data, it won't match. I told, sir, it is 1.2 lakh, no, what is there? According to our experience, this is much more than that. Mohan, don't tell this, sir. This is what? The number. I told nothing, sir. We are not here to highlight what is the number. We want to prevent that, what we can do best. See, this is something which we are actually struggling about. So, the realization is, with all this happening, that what is the best way? Where exactly? Who understand the context better? Who should use the data? Who understand the realistic situation? Who can reach the vulnerable population in the last mile connect? Is it the central government? It is the state government? It is the district administration? Who? These questions are started coming. We are talking about holistic. I will tell you, it is impossible to converge these 4 ministries who works on the nutrition. that is WCD, health, education, social welfare with all the hostels, bring them together. All four secretaries don't talk each other. I'll tell you my experience how it went with all full government support into that. And also, who makes the right decision? Who is supposed to be accountable? See, these questions are dropping around. Then we thought, one governance system we should strengthen is the panchayat. With the 73rd amendment, you being a CEO, you know that how much empower. Central government has a power to collect tax. State government have a power to collect tax. Then only panchayat have a right to collect tax. So this experience of very strongly believing the panchayat system, who can see the change locally, who can actually address things holistically. This is something which we did. And I'll tell you, Parliament, they are struggling and fighting for the women participation last from how many decades? 7 decades. But Panchayat has a reservation of 30% for women. Now it is 50% in some of the states. So women participation is ensured there. So see, if you see the positivity of the things, even in the act-wise, it is highly decentralized thing which any governance system can address. So these are the few things actually made us to think that last 1 year I was just seeing that, analyzing the tax collection of Panchayat, it is increased fivefold, 350 crores to around 1,600 crores in the state of Karnataka alone. I'm not talking about Kerala. Kerala Panchayat is somewhere. Okay, I'm talking about state like Karnataka, Maharashtra, and Rajasthan and all. Very good panchayat system we have, even West Bengal. So they have power to collect tax and they have a power to spend. But where they spend, that is where we need to ensure. I think with this philosophy of having a Gram Swaraj, local self-government, we started calling Gram Sabha is Vidhana Sabha. So that is the empowerment process, is in a belief system. It is not that easy because there is also other side of the coin. People talk about, no, see, they are corrupt, they don't participate, the women will not participate, men will participate. I think these kind of stories, other side, it keep hearing, but things are changing. We need to have a long-term plan to build the capacity of this panchayat and the local governance system. With that philosophy, we started with this. Thank you.
Sir, thank you for sharing this. So now we will take only one question because we have less time. So I request one question. Yeah, from the last. Yeah, please.
And a very frank opinion you have given. I have a question about when we are talking about the Sarpanch, Gram Sabha, their agendas are totally different. Mostly monetary agendas, roads and all that. But can you elaborate on how you have shifted the agenda of monetary to the health and nutrition services issues? I think that has been discussed in the Gram Sabha and in the Gram Panchayat meetings. So, thank you.
Anyway, I'll take that question later part, but to give one example, I'll tell you that it is not an overnight shift. Okay. One shift which I can tell you right away. Panchayat collect tax, in that some portion goes to as an health cess. All these days what we have seen, health cess is used for chlorination of water and drainage, bala bala. Okay. Last our intervention, we have changed around 60% of the panchayat use that money for the empowerment on the girls' issues, especially with the adolescent, nutritional thing, and also educating on the child marriage and so on. Like different, we had put 10 issues which they have spent. Majority of them, they started spending that. That is the one of the indicators which we got, that how the panchayat mindset is shifted to seeing the holistic development with the specific local issues.
Great. Thank you, sir. Thank you so much. My next question is to Dr. Rajan Shankar, sir. Sir, we know that you have huge experience of working in nutrition field, in GAIN, in Tata Trust. So with your experience and learnings, we just like to know that with your experience, like how private sector, a food market, or maybe a hospitality department, all these can support in basically addressing this malnutrition, how private sector and all, especially with your experience of food fortification, if you can give some idea on that. Yeah.
Thank you, Prem. With your permission, if I may just digress before I come to this private sector. I think we heard, the morning, what set me thinking was, the administrator, the IAS officer very clearly said about, she's worried when she hears about the scale, and we also have this session as best practices, scalable preventive approaches. I'll just make one statement before I go to that. Like Rajini mentioned a very successful initiative. Mohan talked about, how they use panchayats. And there is just no dearth of successful solutions for this seemingly intractable problem. The real issue is many of them work at very small scale and they also work very slowly. What we really need is solutions, all this merge, and we need scale and speed. From what we repeatedly hear, the scale has to be scale with equity focus. It's not just scale for the scale of number. A scalable solution which doesn't take care of the most vulnerable it's unlikely to change the things. So, and also, as we discuss these successful solutions, we should realize there is no dearth of policies or programs in our country. Over the years, anything that you take, we have the right policy and a slew of programs. Even what is coined as a 1,000-day initiative, if you look at the interventions that are the package of interventions, they're all very much there in ICDS. They've been there since 1975 when it started as a pilot. There's nothing new that has been added. But what we really find is it is not that we need new programs. We need to implement them better. There is a real issue with implementation. There is a real issue with seeking. People who need it don't go there because it is implemented poorly. And over a period of time, successive evaluations have given such a bad name to the entire system, and people are not motivated. And so it just is going into a cycle where it has become a vicious cycle. You have to change this into a virtuous cycle of if you improve program delivery, correct the implementation failure, more and more people will go. As more and more people go, more and more motivated workers will implement. Now, sorry for the digression. When we talk about the private sector and nutrition, we always think more about, say, food fortification or, some processed food. But we will have to look at nutrition and diet as a whole. People eat food. People don't eat nutrition. If we take what, say, Subbarao would say as a recommended diet, you've just classified them into 9 or 10 food groups. Many of them come from private sector. More and more people are into cash economy. We are no more a subsistence agriculture economy. More women are in the workforce. Most of our population look at the market for their food need. Food is not just processed food, what we, fortify or we reformulate and produce as, what is available. It is all the agricultural produce that eventually go as food. We've got to work with the private sector, those who produce food, those who process it, those who move it, and keep it ultimately at the sale point. So if you look at it as a whole, the engagement of the nutrition and health sector with this entire food system is very minimal. We are not working to change the agricultural policy. We're not working to change, say, the logistic issues. We're not working to change how the food waste can be reduced. I'm fortunate to work with a group of people who have been analyzing the household consumption expenditure survey data, and the results are ready. Very soon there will be a dashboard that will be released for the country. People can see. You find that the diets are improving. Even at the bottom 20%, diets are improving, but there is a lot more to catch up. That will only happen if we work with the private sector and improve the logistics, improve the storage, improve the processing facilities. And for all that things are there, we need to improve better. Food fortification is a very small addition to the whole. But I think adding food, a supplement or through a fortification can never replace food. It is supposed to be a supplement to what actual diet has to contribute. And towards that, I think there's a lot more that the private sector can do, and we should widen our understanding of engagement with private sector. That's my submission.
Thank you so much, sir. Thanks for these insights. Questions from the audience? Yeah, please.
As we are talking about nutrition and malnourishment, so obesity is another part of the nutrition and food. As you said, people are just eating food. So do we need to think about obesity as well while we are working on 1,000 days? Just want to know your opinion. Obesity. Yeah. Just want to know your opinion. Do we need to think or do we need to work while we are working on 1,000 days? Thank you.
Yeah, I think, we have all those cliches, as he said, you call it double burden, you call it triple burden. Basically, this is a part of the nutrition transition. And we are moving from, basic food to more processed, energy-rich, energy-dense foods. And at the same time, our activities are also coming down so much. We are not going to win this battle by just focusing only on processed food. It is an important thing. We have to see that that doesn't go up. But there is very little conversation on improving activities. There's very little conversation on, what people need to do as diversifying their diet. Just pointing and finding the private sector and processed food as the villain is not going to help us win the battle. There's a very clear set of recommendations, what they call as double duty action from WHO. There are 10 clear points that says what we should do in situation where you have undernourishment and overnutrition, not only in the community, even in the same family. Even individuals who are undernourished when they were young tend to have the tendency to become overweight, obese, and more likely to develop, the problems, metabolic problems. So the issue is we should focus on processed food. We should focus on, activity more. And most important is diversifying the diet. And that is possible, and we are getting there. Our diet in India, even in the bottom 20%, is getting diverse, but not as much as we need.
Great. Thank you, sir. Thank you so much. So now my question is to Ms. Meenal. We all know that government is fond of numbers. They usually measure or monitor how many SAM, how many MAM, all those things. If you can share your experience, especially the collaboration with IIT Mumbai, where you develop a learning action protocol, instead of focusing on monitoring numbers or SAM and all, the focus was specific to weight gain or outcome-based accountability. So if you can share that, please.
Hello, everybody. Just a small correction is that I had never developed LAP. I was given LAP by IIT Mumbai, and there was a small role played by me and a couple of other officers across Maharashtra who've implemented learning and action protocol via the health spoken tutorials of IIT Mumbai. So as an administrator, I can tell this, that we live in complexities day and night. Multiple stakeholders, expectations, demands, and what we crave when we look at the civil society is that somebody comes and tells us कि probably ये दो चीज़ें कर लेंगे तो इसका impact यहाँ हो जाएगा, because also most of us are generalists. Like I can tell you that I am a bachelor in arts and I have very little technical knowledge of, let's say, what nutrition is, how to look at it from the medical perspective. So I would love if, the civil society comes up to me and says, these are 3 things, if you can do this, there'll be results, and we can definitely pilot it around that. So LAP and health spoken tutorials was what gave me that in my head. We've all heard about home-based neonatal care. And if you ask any health worker frontline, they will quickly describe what is an HBNC. They're like, पहले, तीसरे, पांचवे, सातवें, 14th day पे आपको जाना है, बच्चे को visit करना है. And but if you dig deeper and you ask them that visit करके करना क्या है, they don't have an answer to that. Or they do, but it's extremely subjective and superficial in the sense that they would look at a child and see if he's not crying, he's okay. If he's alive, he's okay. And ठीक ठाक दिख रहा है, दूध पी रहा है, whatever. I mean, there's no such set guidelines which HBNC also gives. So LAP gave us that, and plus coupled with a monitoring app, which was also designed by Srinandan, he's present here, that we could tell the health worker that when you visit on the 5th day or the 7th day or the 14th day, this is how much the baby's weight gain should be. And if it's not happening, you need to monitor the breastfeeding practices much closely. You need to monitor the mother much closely. And there is also no way that the headquarter, so I am, let's say, the CEO, and I'm sure sir knows it, because sir, आपने बोला कि हम अपने नीचे से power नहीं देना चाहते. There are times where we feel कि हम तक बात आई ना. So in health, I felt that at headquarter, I cannot monitor 73,000 mothers in Jalgaon. I cannot monitor what's happening in their homes, and is the baby gaining weight? If not gaining weight, where is it not gaining weight? So the app and the protocol gave us methodologies where we could monitor in a broad sense, in a general sense, ki XYZ health worker is doing very good, XYZ is not. This is where they are faltering, this is where we need to bridge it. And I felt like that objectivity was of great help to us, because we already short on time. We are dealing with 17 other departments except health. So that comes handy, and that came handy to me was LAP. I was extremely happy that the app could direct the health worker to a solution which may or may not be handy, but it could tell her that if the weight is not being gained or XYZ is not happening, this is what you can do. Or it's another maybe. And it's at her own level. And I can tell you from my experience that most of our frontline health workers are averagely efficient and exceptionally hardworking. So when we burden them with a lot of knowledge and not actionable points, they somehow get lost. And that's when, as Sir was also saying, they start impressing every other CO and collector that comes in the district. They'll do what they say. But they know that ye to 2 saal mein chale jayenge, and we just have to sing the same poem as they are singing for 2 years. So I feel like giving them that skill of LAP via the monitoring app really, really helped us. And hopefully to scale it up in other districts someday.
Great, thank you so much. I think that is important because most of the government, they focus on numbers and fond of increasing indicators. I'll just give you example. I did the MCTS assessment, and we shared the finding with ministry that to enter one day data, per day data, a data entry operator in UP required 48 hours to enter per day. But we shared the finding, and RCH portal is there with 40 more indicators. So thanks to you, that definitely focuses more on outcome and accountability. So question for ma'am, please. Any questions? I think glucose level is going to, yeah.
Very often in a government setup, you know, I've also interacted with very, very passionate, you know, enthusiastic people like you sitting on the chair. But the moment there is a transfer which happens, you know, it's the entire, you know, hard work which you built, it just tends to collapse. So do you have to say anything to this? Because this is very, very common.
I think the person sitting behind you might have a great.
I'll give a very quick answer. I think we have this very strong tendency of making it individual-centric, again, because we get TRP. 30 years back, IS officers were not supposed to be publicity seeker. Right now, at the probationer stage, they say, मेरे YouTube पे इतने followers हैं. Now my point is, अगर popular होना था, तो Bollywood is a much better option. Having said that, the question that she is asking is, how do you move it from individual-centric to process-centric? And talk to many officers who have done this kind of scale-up. Whichever process they have institutionalized survives them. Whichever is after me deluge, it quickly dies down. So how to move away from individualization to process centricity? I think we need to bring out more and more such cases. And let me say this, Tamil Nadu, I have not worked there, but I have experienced it from outside. तमिलनाडु में एक बीमारी है, 2 कलेक्टर ने अच्छा काम कर दिया. You see a circular for all the districts. And that is one of the reasons why Tamil Nadu has done very well in many programs. So I think at some stage, middle, one of this thing, district level officers have to quietly, ढोल बजा के नहीं, move it to the मंत्रालय, saying इसको process centric कर दीजिए, मैं रहूँ ना रहूँ फर्क नहीं पड़ता. That will do transfer proofing of innovation. But if you are, a simple thumb rule is your profile versus the spread of your idea. There's an inverse relationship.
So to cap it also up, I think common purpose brings us all together, like it's got us here. And I'm sure in bureaucrats, one day, if we search for that common purpose, we'll probably go beyond transfers and build institutions.
Yeah, please.
Yeah, hello, myself, Dr. Akash Farman. Ma'am, I have a question for you. You mentioned about demonstrating a pilot or a suggestion by an NGO partner, but when an NGO implements any projects in a pilot mode or in a small geography, it's quite implementable because resources are less and there is controlled population is there. But when we take it to the large scale, what kind of information or the aspects from a government point of view you see to scale that in your district or a state?
I think personally, I'll speak for myself. That is, I look for an outcome-based approach. In the sense, if the NGO comes up to me and says that we conducted this pilot on an XYZ geography with an XYZ economic social profile, and this is what we got out of it. So I would love to study about the outcome and then help them scale via me. But what I've experienced, and not with all, there are fantastic civil society members, and then you do meet some that would approach you more theoretically, with also this expectation, I would say, that the field workers are very committed and they would listen to multiple models and implement it. I had this one NGO in education who had come up to me and say that all teachers are very lazy. So we have gotten this program, and I said, how many teachers have you met? Out of 7 lakh, even if you've met 100, that doesn't give you the perspective of generalizing an entire community. So I would really like if there's an outcome-based tool, an action plan, which is easier, scalable, and it's also digestible by the field workforce. Otherwise, it gets lost in the middle. So this is what I feel.
Great. Thank you so much for the panelist. I think in the first panel, sir has said कि आप जहाँ हैं वहाँ करें. So I want to thank to these panelists. ये जहाँ हैं वहाँ बहुत अच्छा कर रहे हैं. And I really request everyone to please applause for all these good work. Now I request for a photograph.
Thank you. Thank you so much. And I request Dr. Sachin Gupte to please present the panelists and the moderators a token of appreciation and a group photo, please.